minutes before we get started at 6 o'clock. So if you need to get some coffee, some cobbler, whatever, please do that, and we'll get started promptly at 6. Now, in case you're wondering why I'm sitting up here instead of Michael Lavender, Michael was our county commissioner representative. He chose not to run for county commissioner, but ran for a state office and got defeated. So then an at-large member agreed to swap seats with Michael so that we could keep her expertise, his expertise on the Smoky Mountain Mental Health Board, and as the county commissioner official representative on Smoky Mountain Mental Health, I'm your man. So we'll get started in a few minutes, and we will be out of here by 8 o'clock. Wow. Or at least I'm leaving.
And she's riding the
It
diesel.
says at 6 o'clock. So I will be calling this meeting to order, Mr. Brian Staggs.
Pardon me.
See, I find out what your name is, then I call you out.
She does me all.
May I get a fork?
Please.
Okay.
Raise your hand.
We don't want you to get your fingers.
I'm elected clean.
So I am calling this meeting to order, and before we get too far in, Shelley, is this when you want to talk about travel reimbursement? Shelley Foreman. Smoky Mountain Mental Health
Two
Staff.
things. I know that Ryan has sent you information about forms that you would need to fill out tonight, which we need to process you and do payment along with the canceled check with your checking account number, or I see a deposit slip that works too. If you will fill that information out, if you have it tonight, and before you leave, we will get that to Ryan. Also, in your packets, you have a mileage form. That mileage form is for you to fill out, and please be complete. Everybody has to sign, put their address, and make sure they give complete information. And that is for you to document your mileage. If you had calculated your mileage one way and you do that tonight, that's fine. If not, you can always scan it and email it back to Ryan for processing.
Any questions? Thank you, Shelley. Call to order and roll call. I'm not sure about roll call, and I know we have some new advisory committee members, so what I want to do, start with me, and give my name, where I'm from, and if I'm taking Kentucky or the field with a basketball tournament. Vicki Green, Jackson County Commissioner, and I'm going with the field. I hate Kentucky. Brian.
Brian Ingram, I'm CEO of Smoky, and unfortunately Davidson's already out of it, so I have no opinion.
Nathan Bennett, Yancey County Manager, I'll take the field.
Good for you.
Jeff Whitson, Yancey County Commissioner.
Wow. Connie, what about you?
Graham County Commissioner. I'll do that. Everybody else take the field.
Greg.
I knew.
Greg Cable, Graham County Manager.
Kentucky or the field, Greg?
I'd say Kentucky.
Okay.
Paige Lamell, Transylvania County Commissioner. And I'm taking the field because I'm a Duke fan.
Hey,
Ira.
Dookie.
Yeah.
And I'm Ira Dobb, I'm the Haywood County Manager, and I'll take the field for Southern Carolina.
Carolina. Bill.
Bill Upton, Haywood County, and I hate to say it, but the best team is either the Kentucky's first or second team.
Darren Geoff, Watauga County Manager, and I'll have to stay in the field because I'm a Michigan State fan.
All right.
And I'm Billy Kennedy, County Commissioner, Watauga County, and I'm more fascinated by, they say it's March Madness going to bring in like $2 to $3 billion, but then they said there's $2 to $3 or $4 billion in lost time from it, so it's hard to say what's plus and minus, but the numbers are interesting to me, and I'm a Carolina and Duke fan, so I could go either way. So.
You can't be both.
Well, I've got my dad did his master's at Duke, my kids went to Carolina, so I can't be both.
I'm Bobby Irwin, County Commissioner from Allegheny County. I was looking through the pool here, and I'm second to last as it is right now, but I'm still a Carolina fan, see what happens there.
William Sands, Ashe County Commissioner,
You got an opinion on the
Carolina.
Kentucky or the field? Carolina, okay.
Judy Poe, Smoky Board member, and I take the field.
Stan Kaiser, County Manager, Caldwell County, go Heels.
All right.
Steve Smith, Henderson County Health Director, UNC.
Blake Vance, County Commissioner, Avery County, and go Blue Devils.
Chuck Wood, Jackson County Manager, take the field. Plus the Devils.
Vern Grindstaff, Mitchell County Commissioner, and I'll take whichever one you guys can lobby me the hardest for.
A man of true principle. Charles.
I'm Charles Vines, the county manager in Mitchell, and my granddaughter is a student at UNC, so I'm going to take UNC, but I think Kentucky's going to win.
Shelley, what about you?
Shelley Foreman, Senior Director for Planning and Public Affairs for Smoky. And my niece Emily informed me that I am a Tar Heels fan, not a Duke fan, and that's all I know.
Fred.
Ryan, please.
I'm Ryan Barber.
Oh, Ryan, I didn't see Ryan, sorry.
The administrative assistant for Shelley Foreman in Planning and Public Affairs. And I have no comment about sports.
Say. Fred Yearday, I'm the CFO here at Smoky, and anything but Kentucky.
Tracy.
I'm Tracy Hayes. I'm Smoky's General Counsel and Chief Compliance Officer. Let's see, my husband has been a professor for both Duke and UNC Chapel Hill, but we lived in Chapel Hill for 7 years, so I'm going to North Carolina.
Okay. I think that covered, would you like to introduce yourself? Or
You'd like me to?
No, just Donald.
Well, who are you?
My name is Donald Roos. I'm the Provider Account Director here at Smoky, and I work in the Provider Network Department, and go Heels.
Thank you very much. Call to order, roll call. I would entertain a motion at this time. You had the agenda, sent out an email form that we approve the agenda. A motion?
Move we approve the agenda
Billy?
presented. Billy Kennedy.
Second. Second. All those in favor, say aye.
Aye.
Opposed? Well, we got the agenda approved. I would also entertain at this time a motion. You've had opportunity to review the prior meeting minutes. I would entertain a motion to approve those minutes.
So moved.
Billy Kennedy.
Second.
There we go. All those in favor?
Aye.
Opposed? All right. We have already introduced the new advisory council appointees. Shelley, it looks like it's your turn.
Okay. I'm sorry.
Are you trying to eat?
Yes. One of the things that Smoky takes very seriously is confidentiality. That would be confidentiality in dealing with any consumer or families that we serve, as well as any kind of personnel issues. Typically, for any advisory committee member, whether it's board of directors or a body such as yours, we ask that you sign a confidentiality form. This form is saying that you will adhere to our confidentiality requirements and hold confidential any information that you may hear in this position as it relates to either an individual, consumer and family, or any staff or personnel issues. I think by the nature of what we do, that's something that you won't be hearing a lot about, or very rarely, but I do think it's really important for you to know that anything that happens within the context of this meeting, that you would not take it out and share. Tracy, is there anything you'd like to add? And if we ask that you read this and sign and return to Ryan and I before you leave, so we have this on file, as it's a requirement for our accreditation agency. Okay, thank you.
Okay, so we are down to other business, is that right? Help the staff, this is where staff comes in handy. We're down to other business. Membership appointee to the Smoky Board of Directors Performance and Quality Committee.
Right. We discussed this at our last meeting. The Board of Directors has several subcommittees. One is this committee, which is the Performance and Quality Committee. Its role is to look at a whole variety of performance indicators, data, information related to how Smoky is doing based on the requirements we have as an organization, how we're reaching our goals that are expected of us by the state, whether it's the Division of Medical Assistance or the Division of Mental Health. And we take that very seriously. Last year, Smoky did start this committee so that there would be a focused group of board members who would be able to better understand the very large amount of information and be able to report back and synthesize that to our board of directors. The chair of that committee has asked, and one of the things they would like to do is to have a member sit on that committee from this group. Even though you would not be a board member per se, you would be invited to that committee meeting to hear about the information, to report back to this group, and to, of course, you're welcome to stay and participate in board meetings as they occur, as they're open to the public. So didn't know, I know we talked about it last time, people were going to think about whether they could do this. The meetings are typically 10 meetings a month. They are on the fourth Thursday.
You said 10 a month.
Oh, 10 a year. It feels like, okay, where's Jill? Jill would say 10 a month. It's the fourth Thursday of every month. So I guess, I don't know if anyone thought about it since our last meeting, would like to volunteer, or if you would like a follow-up email for us to solicit volunteers. It's really a great committee, and it's, I think, an important committee in being able to report back to this group about where we are in our performance measures and standards.
Does anyone here tonight have an interest in serving on this performance and quality committee? Okay, then we will send out an email, right, Shelley?
Yes,
Okay.
I'm not going to stop asking, so. Thank you.
Thank you. Smoky board vacancies. We had anticipated that the introverted, quiet Ronnie Bill would be here to talk about the vacancies on the Smoky Mountain board, and the two folks that we are recommending to the full board be appointed to take those vacancies. We do have a letter from Ronnie Bill, one of the first things in your packet, where he made the recommendation that Ira Dove, county manager in Haywood County, former DSS director, attorney, county manager, be one of the appointees, and Mr. Billy Kennedy, Watauga County Commissioner, who has been very vocal about his interest in Smoky Mountain mental health and being on that committee. Now, these two names came from the nominating committee. We actually met in a conference call the Monday before February 24th. And then, as we know, we did not have a meeting on the 24th. So this is just to advise you what the nominating committee's recommendations will be to the full board. However, in that conference call, I did make the recommendation, I hope somebody heard it, that Smoky Mountain do the same thing that Jackson County does, which is have an application form for volunteers so that when we do have vacancies from time to time, there is a pool of names, people who are interested in being on the Smoky Mountain Mental Health Board. So, and I think that's worked real well in Jackson County for us, so that we don't have to go to our friends and neighbors and beg. Does anybody have any questions about those two folks? And I guess.
You don't need a motion?
No, this is just information.
Okay.
Because the nominating committee will, do we?
There's no motion, but we do want to solicit your input. So we do want to make sure that anybody who has any comments, questions, this is the time for the County Commissioner Advisory Board and your role as serving as the chief advisory board to the full Smoky board, that you provide any input or comments about the recommendations of the nominating committee.
I've worked with both, and they will ask the right questions.
I believe you're right. Well, I'm glad that our Board of Commissioners thought he had enough time to serve on the Smoky Mountain Mental Health Board. Thank you, Bill, and thank your other commissioners there. So those are our, and I do chair the nominating committee. How I ended up in these positions, I don't know. Those are two recommendations, and Brian, I do hope that we get some sort of form that's available on the website or is sent out to county commissioners and people who may be interested for future vacancies. We also had Rutherford County come in, and would you introduce yourself?
I'll stand first. I'm Brian King, I'm chairman of Rutherford County, and our manager, Steve Harrison, is here. So,
Thank you, fellas.
we were fashionably late, we had a meeting and ran long.
Imagine that.
Preparing for the future, Smoky planning with Mission, Mayhap, and WC Health System, and state activities. Brian Ingram.
Okay, thank you.
Mr. Ingram.
Brian is fine.
I'm just showing off.
I know, I appreciate it. You know, I'm gonna say that for the last thing I talk about, that's a little lengthy. You know, there's several things in your packet that you can have whatever discussion you'd like to tonight, or just read at your leisure, or what have you. I'm not sure there's a particular order, but let me go in the pile that I have. First off, House Bill 119. I want to take a look at that. And this is not the actual bill language, it's a summary. Pretty significant because it is a piece of legislation that would take the money that is used to directly fund the state operations of the alcohol and drug treatment centers, of which we have one in Black Mountain. Instead of the state funding those directly, give the money to the LME MCOs and have us contract for service just as we do with other providers. So it's certainly is a big effort for the state to get out of the business of having direct service. And I think everybody knows that they do that both in the case of these facilities, intermediate care facilities for individuals with intellectual and developmental disabilities, and psychiatric centers, of course. A lot of momentum behind this, so I suspect something looking a lot like this will end up as a final piece of legislation. And as much as DHHS has tried to promote some opposition or resistance to it, I don't see that being successful. So I think over a period of, I guess it's 3 or 4 years transition, 2020, we would see that money come to us by some methodology based on the utilization, which is not completely determined yet. But I think you're going to see something that looks a lot like this coming to be legislation. If you have any questions about that, I'm sure your county association will be watching it. You know, I could, I would love to be able to tell you that I'm sure that this will be a positive transition. I think over time it can be. This is a very, very vulnerable population of folks that receive care in these facilities. Often they have, you know, very significant issues with addiction and comorbidity with medical problems. So it's, you know, it's a level of care that is consistent with inpatient hospitalization. So, you know, the reason that there aren't any of these in the community would be a good indication of why the state provides it. You know, there's no competition for this. No one else really does this. We don't have a lot of inpatient hospitals that provide this level of care. There's very little inpatient detox. So how we would make this transition from it being a state-operated service to one where we would contract for it, the existing capacity that is involved with the state delivering it, that could change. And on balance, I guess I should point out that there's a lot of questions about the efficiency of the state, providing this service, differences in cost. There's a pretty lengthy PowerPoint that's been presented to different legislative committees that if you were interested, I could share that with you. But it's a pretty important piece of legislation. I'm sure you want to keep your eye on that.
Brian, a quick question. If this went forward, would multiple LME MCOs be tied to that Black Mountain facility, or would it just be you?
Yeah, I don't know, is the real answer I have to say. Now, that's not going to stop me from trying to answer your question. Somehow they're going to have to look at historic utilization and divvy up the money in relationship to that methodology. I don't know how else they could do it, unless there were some trend factors that they thought would influence utilization in the future. They do that with our rate, when we're having those negotiations with DNA. And then, let's say for Black Mountain, we use 80% of the beds there. The bed days, really, is how I should put it. So 80% of the funding would then come to us. And that's a pretty simplistic view of it. I don't know how else they could do it. So if you weren't a big utilizer of this level under care of the past, you wouldn't be getting much money for it.
Is that the only program in your catchment area?
How many of them are there in the state? It probably says half a dozen of them. Not a lot.
And I think that's part of the problem is there's not enough. And, I think there could be concerns on a lot of different levels. And that, if we're going to let you all manage this aspect of mental health, there certainly needs to be additional facilities and access provided within our respective catchment areas.
That's our, that becomes, our problem. That's our responsibility. They would basically, it's I want to say a shell game, that's probably not fair, but the money, let's say it costs $100 to run, and there's 3 of them, I'm just reading the first paragraph. Let's say there's 3, so it costs $300 to run these. What they're going to do is take that $300 and instead of directly funding those organizations, they're going to send that $300 to the different LME MCOs.
Right.
They don't want to be at risk for how much these things cost. Okay, there's another way if you want to just kind of look at it, maybe through a different set of glasses. And the way this works out now is they always have that responsibility. So if, it costs more, if it costs $310, they got to come up with the other $10. I don't think they want to have, it's just like the Medicaid program, like a lot of other payment and financing the state is involved with. They do not want to be at risk for that payment. They'll write a check for it, and then that's it, and have a contract, and then that's it. They don't want to have any more responsibility for it financially, really.
So are you going to determine the amount, the people that are eligible to use this service by the amount of money you provided or by the need for the service?
We do it by the need.
Right, but do you think this could be I wouldn't be surprised if the state didn't fully fund what this needs to be. And I'm wondering if that could be a problem for Smokey, trying to meet that need without the adequate funds.
I've talked about it all the time. It's impossible for us. I don't want there to be any confusion about it. It's impossible for us. Okay? These are individuals that don't have Medicaid. The majority of individuals in North Carolina, let's just say, given the way Medicaid entitlement works and addiction, a lot of people that need service do not have Medicaid. So that means that it's funded by state, county, and to some degree federal block grant funds. These monies would go into that pool, basically. And there's nowhere near enough of that money to provide the services for that population of uninsured and underinsured. Okay? A huge discrepancy between the number of people who are uninsured and underinsured and need care and the amount of money there is to provide service. Judy?
Brian, are you saying instead of the money going to Black Mountain, it would come to Smoky? Okay, if Smoky don't fill half the beds at Black Mountain, what's gonna happen to them?
Anybody else could.
But I mean, if there's not enough,
They'd be like any other provider, okay? It's not a guaranteed, all the providers we deal with, they don't have any guarantees, so to speak. They do what is needed, and what they know we're going to pay for. And, that drives certain economies and certain quality and best practice. There are services that we could think of over the years that have been found to, not be as helpful as others. So if you're a provider and you want to do that service, you can go right ahead, but we're not going to pay for it. It's about the client, you see. At the end of the day, it's about the client and what the needs are. And now, don't get me wrong, it is a very valuable service. That's the first thing I said when we started. And there's always going to be a need for this level of care. Who provides it, where it's provided, how much it costs, all of that is going to have to shake out. And there's not a big line of providers waiting to say, oh gee, can we do this?
I've got a question. This is my first meeting, so I'll try not to speak out of turn, but is this driven by money or what's best for the client?
I think it is primarily driven by the desire the state has to not be at risk for operating a service and the potential financial risk for that. I think that's the largest feature. And they have someone in the form of the LME MCO that they can offload that risk and responsibility to.
So the answer is it's driven by money.
Yeah.
So does
roundabout way.
the state own these centers? Does the state own these centers?
Yes.
And they'll transfer ownership to the LMEs?
Now, this is the thing that's screwy about it, to me. The suggestion I had was, why don't you do just like the area programs do? Let them become nonprofits, let them become for-profits, let them become like all the other providers in our network. Right? Just like when when the area programs privatized, divested of their services. You remember all the, from people sitting in this room, you're talking about El Smoky, Foothills, New River, Western, you got 4 area programs, excuse me, that all provided a lot of services directly. They had to get out of the business of that. Just like the state is trying to get out of the business of being a direct service provider, but yet they're retaining the ownership, you might say. So they're going to continue to be state employees.
So they'll actually own the facilities and manage and operate the facilities?
There'll be state employees and there'll be state-owned facilities. The payment for it will be generated by fees for service that they receive from us.
So you're going to be paying the state to operate their building?
Well, yeah, we're going to be paying, that's correct.
With money that they gave us.
Right, right.
Will you be able to control the quality measures like you do with other providers?
Be like anything else, we'll contract, our contracts are a matter of, well, just all the things that, that I was alluding to.
Yeah.
There's certain requirements around having a contract with us. And we go through a credentialing process, there's quality, all of that, yeah.
All of that, but with the state, on the state, that's going to be an interesting relationship.
I suspect that, because these are big employment centers, you can talk about this as economic development and jobs for people. Politically, do you want to give up all of those state jobs in your area? Probably not, right? So I think there's an element of that in it as well.
Will the state employee rules come your Smoky rules? I mean, not you're talking about quality and stuff, and if you have employees that you can't really, that you're only half managing, then
It's like, it's like our other providers. Really, we have non-for-profits that are, small organizations. We have multi-billion-dollar for-profit organizations. I mean, how do we control them? We have a contract with them. The contract has certain requirements that we apply, very consistently and fairly. And then we have a reimbursement agreement.
but those you can cease to engage.
And
will
we
you
can
be
do
able
the
to?
same thing here.
Okay, all right. So you will have that out if it just doesn't work.
We always have that out. There's a whole other interesting situation, but, yeah, we do have that, always have that ability. We have a closed network. We're really having some managed care talk now. See, when you only have a limited amount of money to do what you gotta do, you have to make hard decisions, as you well know. Same for us. Okay, well, anyway, it's a good discussion. We'll see how close the sausage looks like this at the end of the session. Let's see here, the next one. Ronnie cares very deeply about, mental health issues, and when he became the chairperson of the County Commissioners Association, established a task force, mental health task force, and myself, along with a couple other MCO CEOs, presented at that 2-3 weeks ago. It was kind of a round robin sort of thing where we, they created an agenda. It was up in Raleigh, and talked through a lot of issues that they were concerned about, and each of us made different, I guess we kind of contributed to conversations and then shared some information that we thought would be especially germane to areas that counties are sensitive to. The things that I brought with me was this one sheet page. Accountability always continues to be something that people, I don't know whether it's question or need to understand more about. If you don't think there's a lot of accountability with what we do, please read this over, and you can ask us any questions about all of these things that we have to do for a lot of different folks. And believe me, compared to the area program days and now, there's no comparison. The amount of oversight and responsibility and accountability we have now is probably 10 times that of what it was previously. So it's really odd when, we see these, maybe some comments, not necessarily from anybody here, but elsewhere, about accountability for what we do. It's gigantic. Gigantic, and this is just a sheet that outlines it. So if you have any questions about any of that, I'd be happy to talk about it. It's makes my head hurt just looking at it, thinking all that's involved with this.
So you say it went up a lot in the last few years?
Oh, by participating in the Medicaid waiver program, yeah, it went up just ballistically.
And so you're having to spend resources to meet those requirements.
And it's just how it is, step back from this whole thing, Bill. You think about what we're doing, what the state is doing. We're asking the federal government to waive certain rules around the Medicaid program. And in so doing, there's a lot of things that the federal government wants to make sure are in place so that you're not spending, just less money. You're not denying care just for the sake of saving money or something, kind of the sort of the gross ideas that people may have about managed care historically, which are just, it's just not what we do. But a lot of other things about quality as well. Well, and of course, the state in its infinite wisdom adds on to the pile of all the things that they think are important. both in relationship to our operation with the Medicaid program, and it's like we're a whole different, like a whole different insurance plan, if you will, or benefit plan for those that don't have Medicaid. So there's all the rules and all that goes with that, so that's also part of what's on here. So I think it's fair to say there's a lot of accountability. So. Okay, so that's that. And then there was another one that went with that. Where is that?
You're in the rest of the show, Ron, so
Mm-hmm.
how is the rest of the show?
Yeah, there's another sheet about all the
Oh, it's, we were gonna
community
have,
collaboration and not making it in the
well, I'll
packet.
hand it out, Brian, you have it
Okay.
already.
The furniture around tonight, oh, here it is.
Yeah, this is a really good one.
Well, there it is.
And I tell you, I read this and I have to be reminded of all the things we do in so many places. It's not easy having the geography that we do. It makes a lot of things more difficult. But we have a real commitment to spending a lot of time on the ground, doing as much community education. The work that Jenny Pugh does, our Senior Director for Community Collaboration, Rhonda Cox with Care Coordination. We have about half of our staff are involved in some way, shape, or manner in the community. You know, these are people that live in your counties, work in your counties. They go to work at DSS. We have shared relationships with DSS, public health. We're in different providers' offices. I mean, it's about as grassroots as we can make it. And that's an important part of what we do, despite our size. And I looked this up at one point to see how many states we're actually bigger than. It's a few. We're about 10,000 square miles. That's a lot of territory to cover and a lot of people to cover, but, you know, we're very committed to, you know, our engagement in kind of that grassroots level. And just some of the high points, the mental health first aid, and I'm hoping you've heard of some of these things, darkness to light, wellness recovery, action planning, RAC, crisis intervention teams that are in existence. You know, the training we do, it's phenomenal. 500 officers since 2008. I mean, we just do that about nonstop now. It has a great, you know, reputation. Very big development here with this facility, and hopefully you heard about that in the media. You know, we're in the process of moving out of here. I think our administrative wing over here is the last to go. We're packing this week. We're going down to Ridgefield Court. This whole facility is going to turn into an urgent care center where we would have a 16-bedded program that will be a facility-based crisis program. We'll have a respite program where we actually have lounge chairs for folks that are able to be in a safe, supervised environment and just kind of gather themselves under some supervision. We'll have all kinds of outpatient treatment, both walk-in and what you think of as normal kind of outpatient therapy, psychiatric care. We're going to have a pharmacy on site, and we're going to have a peer program. So it's really, and when you imagine that the main part of that, the walk-in part, the bedded program, the crisis center is going to run 24/7. That's quite an asset. And we're very committed to that, serving all disabilities and really reducing the inflow that we see at the emergency departments. So that's the result of a grant from about $2 million from the state, about $2 million of Smoky Fund Balance, and contribution of Buncombe County and Mission Health Systems. So these are very expensive endeavors. It's a real big deal. Got a lot of positive response in the press and in the community. Also in...
Is that really a regional summit?
Yeah.
So the expectation would be that counties would bring
Well, we have other facilities like this in other parts of our catchment area. We have one in Balsam, that is right there, when you go over Balsam Mountain right there, that's run by Appalachian. And then you see the next heading down is in Caldwell County. We're involved with putting up another similar facility. Won't be as sort of large scale as this in terms of that 24/7 operation, but same thing, where we have the ability to have walk-in, multiples of levels of care in the same facility is really the key. So hopefully in that neck of the woods that'll help. And then there's another similar program, a little bit different, Carl Space. Where is that? I forget where that program is, up in the north somewhere.
Which one? Oh, Synergy.
Yeah, Synergy. You know, Donald?
Thought they were in Caldwell.
I don't know. Anyway, it's a smaller program. So, we'll be building capacity for that level of care. And, what we find a lot of times is people end up having acute admissions to the hospital where really, but they need that level of care because we don't have anything else. But if we have this, you don't need as much of the hospital, and you don't need the emergency department.
How many beds did you say, Brian?
16. And the story gets even better, because what we're going to do is there's an existing program in town, and it's called Neil Dobbins, and that's run by RHA. So they're going to transfer those beds over into this facility, okay? Now that existing facility in Neil Dobbins, which is right down the street, we're going to turn that into a youth facility-based crisis program, which will be one of only 2 in the state probably by the time it opens. So again, another, the kinds of, very unfortunate situations, that I hear about, and I know you folks do, with young people who end up in the emergency department, and again, need a much different level of care than the ED. Do they really need an inpatient program? Well, sometimes, but often, this level of care is just a tremendous benefit to folks. The average length of stay being, 4 or 5 days, and do a world of good. So to have 2 of these programs opening in roughly the same time span, is amazing in this day and age. We're very happy about that.
So
That's all with a smile. Yeah, I think you are.
are you hoping to have those geographically centered throughout the catchment area eventually?
I wish we could have one in every county. But when you consider this one here, probably the lift on it's about $6 million.
Got the numbers yet?
Yeah. So, it used to be $1 million with a lot of money, right? Now it's,
Still a lot of money.
We're back to the same thing. A lot of the expense is for individuals who do not have Medicaid. And whether you want to think this is an advertisement for expansion or not, you don't get to have it both ways. That's what I'm always going to tell you. We have the best system that's been paid for. That's all. And if people don't have Medicaid, you're going to have a lot of people in the jail and in the EDs and in all kinds of other places because people don't just go away, right? They still have the same needs. They just don't get the care at the right time and in the right place and have the best outcomes for recovery. And that's just true. We know that. So that's one of the things we struggle with. Why the expense then comes to the hospitals and providers and us when people don't have Medicaid benefits. So.
Brian, I can't resist why I have county managers and commissioners in the room together. On your sheet, Brian mentioned a training called Crisis Intervention Team Training. That is a very focused training that Smokey and several other organizations put on, focused at law enforcement officers. It's based on a national model by NAMI, the National Association for Mental Illness, does on helping law enforcement better respond to individuals who have mental health, addiction issues, or developmental disabilities. So if you have any interest, or you could talk to your law enforcement, sheriff's department in your county. We are doing more training. We're getting ready to launch a new series of training, and we'd very much like to have as much participation as possible. So you could always just let Ryan know if your sheriff or police departments have any interest, but we would really want you to help us support that.
Where's the training site?
They're offered in a variety of places throughout the whole 23 counties. It shifts, and we can get you the training calendar. We'll actually send that out to you.
Okay, so you've trained 78 officers a year for the last 7 or 8 years, 550 total.
It continues, and as law enforcement officers change and move in and out of the system, we want to consistently offer that training.
Is it a one-day course or 2 days?
No, it's I think nearly a week of time, but most of the sheriff's departments use it as one of their mandated trainings that is required of them. So we'd be happy to get you some more information and a brochure.
Is it a week straight?
I believe. I don't want you to quote me on that. Okay, thank you. I can quote Donald.
There's actually 2 tracks. The original training is a week-long, 40-hour-a-week training. But Smokey's been working on developing what they call a rural track, because we know in rural counties you can't pull your officers offline for a whole week at a time. So we're actually breaking that out to one Monday over a month's time. So we're just taking officers offline for that 1 day a week and sort of breaking the training out over the month to try to make that work for rural counties.
Thank you.
And in no particular order, I guess we could look at this one. Which is a collection of information about the performance of various LME MCOs, and Council of Community Programs put this together. We put it on our own letterhead as far as that goes. Of course, now that we're into the legislative season, it's important for elected officials to understand what we've done. It's still, I think, mental health reform has been a very confusing thing for people, understandably. So it gets hard to understand really who's done what. Is it any good? Is it so-so? Who's been helped? What about the money? We just really tried to point out just some key findings here. You understand, kind of back to this whole discussion about risk. I mean, why did the state decide to have a 1915 BC Medicaid waiver for all individuals in the state that we would operate? What's the main reason for that? Eliminates risk for Medicaid payment on behalf of the state. It puts us all on us. So we have a capitated amount of money. We have a limited amount of money to provide service to individuals with Medicaid. And here's the really tricky part about this. Medicaid's an entitlement. Okay? If you're eligible for Medicaid, which is means tested, you understand how that works, and you have a medical condition for which you meet the criteria for care, you are entitled to receive it. Now, the problem is there's not an unlimited amount of money for that care. So you have to create some kind of a system to say what kind of care and how much. And you have to manage that against the amount of money that's been provided to us. So at the end of the day, is it about saving money? Well, it's about saving the money, or at least bending the Medicaid cost curve. So that's what that first red comment is about, the savings of $73 million. How many times have you heard the phrase Medicaid's broken? Well, it's not broken with what we do. It's not broken at all. In fact, it's very well managed. See the big zeros there? Have any of the LME MCOs busted the budget and gone over in Medicaid? No, they haven't. And again, we're the ones at risk for that, right? Not the state, not even county share for Medicaid anymore. So that's on us, so that's an important feature. We have actually increased the number of people receiving care since we've begun the waiver, which is another kind of good part about running this type of a program, is you can do things to increase the care that's available to people. It's not easy, and it sometimes amounts to saying no to some folks, but we're very happy that access has actually increased. This last one about the kids in psychiatric residential facilities. In an unmanaged system, it was very, very easy for kids to end up in these very high levels of care out of homes because they wouldn't be a problem. They'd be less of a problem. And that's a harsh thing to say, and I could talk about it for maybe about 5 minutes, and at the end of it, that's what I'd have to say. It's just the reality, when no one is in charge of managing the care, it's easy for things to just go to the high end, okay? So for example, when we took this over, took over the responsibility for the oversight, we asked for all kinds of clinical documentation for kids that were in these levels of care, sometimes for years. And you know what we found? They didn't get any better in many cases. There was no clinical grounds to continue their care in those facilities. But
So the facilities wanted reimbursement to continue?
And I can't even say I blame them. It was just, that's how the system worked.
Okay.
Nobody was in charge of that. And it became easy for that just to be what happened. Nobody was looking over it. So what we found was a lot of these kids didn't belong there. They could come back home, we could develop services in the community, and we could manage things, much closer to home with much less cost, and that this whole pattern was really ill-founded. And it's just, one very glaring feature when you go from an unmanaged to a managed system of care. So is it about saying no? Well, yeah, when it's not needed. That's how I would put it, okay? That was a situation where a lot of that, you see a large reduction in kids going into that level of care. Not that they aren't getting care, they're getting a lot of care, they just aren't getting that care. Oh, there's a whole laundry list of great things we've done here. It'll probably make you misty-eyed how wonderful we are. Hope you'll leave this on your coffee table, your waiting rooms. If you want 50 or 100 copies, we can give them to you, and you can put them all over the place. But seriously, we've done we've done exactly what we've been asked to do, and it hasn't been easy. So, there's that. You're doing a lot of talking here, baby.
You're great. You're moving right along.
We're
I
gonna
can
be out of
see us
here.
out of here before 8 o'clock.
Oh, we're going to be out of here long before 8 o'clock. You leave it up to me. Okay. All right. Well, and we missed a meeting, so we've got extra things to kind of cover here. And I'm not a fan of me just sitting here talking all night, so when you get tired of it, let me know. You do this one, MCO communication bulletin. Another big one.
I'm not sure we're there on the agenda yet. I think.
I'm just going to do all of these things and get them done,
That's
and
the
then I'll
mobile,
do the
there are a few
PowerPoint.
pieces on mobile crisis management transition.
Yeah.
I think they're at the very end. For everybody, if you look at, on the right side, it should be, there are 2 documents that have North Carolina Department of Health and Human Services. Yes, those are the documents. So you can take- I moved it all.
A lot of conversation about this one. And you've got hospitals in your counties, you've probably heard about this. This is the one where the state, here you go. Yes, that one. Where the Chuck decided, and then Chuck didn't decide, even had nothing to do with it. The state decided that they were no longer gonna allow reimbursement to occur in the hospital emergency departments for mobile crisis. And, you know, many of the hospitals in our catchment area and around the state are very, very dependent upon that care. You know, they don't have psychiatry, or they don't have psychiatric nursing even, or maybe even social workers. So when people presented with problems, you know, crises related to substance abuse or mental illness, you know, they relied on the care of the mobile crisis team. Well, that had to all stop at the beginning of this month. And it took a lot of work and planning to try to get that coordinated. And again, I don't know if you're getting feedback from hospitals in your area, but a lot of discussion around this statewide. And to be honest with you, I have not heard of any big problems since this change, but we put a lot of work in to try to, you know, get hospitals, you know, basically they're left with either a choice to develop this care themselves, which, you know, certainly makes sense for them to do, or to contract with a provider to deliver it. Again, if you think about how medicine is delivered, that's pretty consistent, right? The hospital doesn't employ every kind of doctor. You know, they have contractual relationships with different, you know, specialty care providers, so you can kind of see how this works. It's just that, you know, in many cases, they're very reliant on that level of care. So it's a big deal.
Do you, Brian, have any idea of what percentage of the hospitals have developed contracts with mobile crisis management folks?
You know, we had to submit a sheet to the state that just was kind of a rundown on that. I think that this was a problem, a pretty big problem for about a third of our hospitals. We have 22 hospitals in our catchment area, so it gives you some idea. And how many ended up deciding they were going to do it themselves versus contract for it. You know, I honestly, I don't remember now.
So does this eliminate the need for the sheriff's deputy to stay with the patient?
It doesn't change that law, no.
But it does require the hospital to provide the service.
Well,
Or to
you're gonna think I'm playing with words, but I'm not. What it means, and if you read it, it says that the mobile crisis program, so those people coming in from the outside, they can't be paid for that anymore. Okay? So the hospital's got to either have their employees do it, or they got a contract for it. Doesn't change the law around involuntary commitment and who has custody.
So but the mission has contracted for.
They do it themselves.
They do it themselves. And law enforcement's not involved.
Law enforcement is involved.
Is involved.
Yes. There's law enforcement right in the ED.
Sheriff's Department or actual police?
I don't know. Yeah, probably Sheriff's Department, I would guess. So, if you aren't hearing anything about this, that's good. It was a big issue for quite a while. You know, people worrying about how this transition will work out. Okay. Very soon, you will be getting a letter, and we have a draft of it here, that has to do with county funding, and, you know, both your budget processes and ours. I think everybody understands the history of county contribution. And, you know, we are trying to come to a place where we're doing this the same for all counties, you know, because we're a blend of different programs over different years, and there were different approaches to doing this. So there were, you know, I guess there were different ideas about how this should be conducted. You know, the law is kind of vague about it, to be honest. I guess probably the most stable process has been the way we have done it historically in our 7 western counties. And then we've developed, kind of extended that process as we brought in other counties and other catchment areas. And most recently with Western had probably the most different process around this than any of the other experiences we have. We're trying to normalize it, and we're trying to put it in terms of really a letter of agreement, or you could think of this as a contract, to just make it much more consistent and understandable. I don't know if Tracy, she had the good sense to run out of the room.
Yeah.
Fred, any thoughts or any comments here?
Well, it's a general solicitation as well as a commitment and communication that goes back both ways. As you understand, there's a diversity of history in regards to this, and given a larger region and that diversity, there is a necessity to normalize it into something that looks more similar. So this is an attempt to reach out to you in a uniform kind of fashion with an approach that we can both mutually agree on, and a commitment financially through the course of the year.
Do you want to say anything about the focus of how we use the county allocation? Because I think that's something is described in the letter, but do you want to say something? Because what we use county funds for are really mission critical services, and those really that are probably the most important safety net for you to have. And that would be the rapid access or the walk-in centers. Every county has a place where people can go, at least one place where people can go for assessments, evaluations, referral to treatment. Part of that and part of the county funds are used for access to psychiatric resources, so people can have their evaluations and have ongoing medication management. And mobile crisis management, as we heard about a little bit earlier, that is a service that is very important for the community, and having people who are able to not only deal with people in crisis, but also to help with working to keep those people from having to go to state facilities or be involuntarily committed. So those are some of the focus areas that we use county funds for. Are there other things you'd like to say about that, Brian?
Not any better than you just did.
Okay.
Billy?
You mentioned the historical reference. I'm curious as to where this has been an issue for our county before, in that we were providing more services, and then the rate just got set by what we were providing. And I'm just trying to get at how you're going to determine some kind of per capita or some kind of rate that makes it fair to all of us, rather than locking in this historical rate, which was just arbitrarily set at a certain time, as I understand it. So that's been a little burr in our saddle in Watauga County, and trying to work that out so that we feel that we're being fair as well as to everybody as well in other counties as well.
Well,
Tell them where we rank on the list in the state.
well, let me explain a little bit more about what Representative Kennedy's speaking about here. The range of funding on a per capita basis would make your eyes roll back in your head. Why it is that way, there is no reason other than to say that different counties had different thoughts about how much money they wanted to spend on services to their citizens. I don't know how else to put it, really, Billy. It's really, it's about your citizens. Yeah, the money comes to us. We're just the agent to maximize the money. I mean, it's really what we do, okay? And I know people get, kind of mad at Smokey, and we're not going to give you our money. Please, it's your citizens, if you're mad at us, that's one thing. The money from the counties, it's all about your citizens, your neighbors, your people, your family, everybody you know. Okay, so please, understand that. There is information in the general statute that talks about maintenance of effort, and I guess in layman's terms, what you came in at some certain point is what you're supposed to stay at. And we've had years where counties have said, okay, but we just don't want to give you any money. And those were very unpleasant conversations. I guess testing the law or what have you. And, this is usually the point in this conversation where I say, I can guarantee you that if we keep going with this, nobody's going to feel satisfied. It's a good thing for people to be aware of.
Don't you get the same answer, Billy, every time you bring this up?
I see it and I know it's about the people, but we've got to justify this at home too. And it's not about turning counties on each other, saying you're not doing your share, I'm doing more. It's about all working together to provide the service to the people. So I understand that, but I have to answer for this at home too. So.
Well, it wouldn't be Smoky that would create, so how would you do that? Okay, you'd have legislation that would try to provide over some period of time, some equalization process to county funding. You name a county legislator you think is going to run that legislation.
Well, I understand it, and I'm just saying this: how are we going to motivate the counties to pay? And not saying if you don't, that's it. But how are you going to motivate and lowballing each other down to the lowest and saying if you don't pay, I'm not going to pay. That's not going to help us at all. So,
I mean, one of the things, that we've talked about in the past, and maybe you to consider, we have county managers and a county commissioner in this room. We would love to see there be some discussion about standardization and how that could move forward. That's something we would love to hear.
And I understand, the rates are going to vary. There's cost of living differences and stuff. So you get a formula, then you adjust it for, whatever the different counties, whatever that funding is. But.
Well, and then there is so there's our 23 counties, okay, and it will be 9 LME NCOs, and then there's 8 others. And I can tell you, they just did a survey. We used to be last. We used to be a third of the state average, okay? So, think about that one.
So on a statewide, you're saying we could go up some.
Well, be careful what you wish for, okay?
We don't like being last.
We're not any longer. We are not any longer. We're up. We came up a little bit. We're still, down there pretty far. And I can't remember if it's about a third or it's something like that. We're like $2.70 per thousand or something, and I think the highest was, I don't know. I don't want to try to sing. I can give it to you, but I don't think you want it.
No, I don't need that. It's just, and
same answer, Billy.
The lowest, we don't want to go to the lowest common denominator. We want to keep pushing up. So.
Yeah, why wouldn't we be doing more?
Right. Tracy stepped back in, and I know you all were talking a little bit about the maintenance of effort and sort of what that means as far as some of the questions that Billy had and the sort of framework for maintaining the current level of support that has been requested and how that could be changed just for a very limited number of reasons, and that's
It's in Chapter 122C, which is the section of the general statutes that governs local management entities like Smoky. There's a particular provision at 122C-116D, I believe, which talks about the
folks. Tracy, would you repeat that for the folks who are
115D.
writing down?
115D.
115D, it's on your memory. And is the statute that requires counties to maintain their funding for mental health to the local management entities. And the Division of Mental Health has interpreted that statute to mean that you have to maintain it at the level of funding that you historically have had, which Donald would probably be the best person to talk about that, at least in the historical western counties.
And in I'm not sure the history of the Western Highlands area, the old counties, but in our previous catchment area, I don't think Smoky has asked for an increase in their allocation for 100, I mean, I've been there 16 years. I don't think we've ever asked counties because we always felt it was important to get counties to come to a basic common, for everyone to reach at least giving what was requested of them. So it's not as if we've requested any increases over the years.
And it is not tied to a per capita or anything like that. So across our 23 counties, we have a different per capita per county. So
We missed all the stimulating conversation about that part.
Yeah, but it is in the statute, and it is a maintenance of effort requirement set out in 2022.
So we would appreciate, when you go back, talk to your fellow board members or managers, expect this letter in the mail, and I don't know where we are, Fred, in terms of the timeline of getting this out.
It'll be out within about a week.
Okay.
So the request is for the same funding next year that we provided this year.
It would be the amount we requested last year.
Yes.
That's historically how we've done it.
Which doesn't necessarily match
Equal.
the amount.
Right, it was what we requested.
Those two may not be the same.
One recommendation, though, may be to get it out sooner, because you've already missed Watauga County's deadline for our outside agency. So again, we've already started our budget process in January, and so here it is. We're almost into April, and to be honest with you, we pretty much going to have a public hearing in May, and this is really a little on the late side to be getting it to us if you want us to really consider it. So that would be my own recommendation.
Okay.
Anything else about maintenance of effort or local contributions? If not, Brian will continue.
Let me make a comment, because I guess Bill and I, on the old board, we went with, against the allocations. Everything, I've been in education, was in education for 38 years. Everything that we dealt with the state was by allocation. What the commissioners work with now is by allocation. When we go back to fellow commissioners, they know what the neighbors are doing and start comparing. And we talked at one time about getting our legislatures to go to an allocation with some type formula. We do this with our school system. I think you're working on it now. Our school system's going to know pretty soon what percentage they're going to get for next year, which cuts down fussing. Because when I was superintendent, I got fussed at over and over again. You're coming up here asking for more money. It would, some of us might have to go up. Some of our small counties, maybe like Graham, you might be giving too much percentage. So I'd still like to see us go to the allocation and take politics out of it. It's still political the way it is.
Thank you, Bill.
And I would echo that and say that I think that it's a worthy discussion to have, because
But if I ever get it figured out for the school system, maybe you could.
I would just sort a lot of things out for all of us.
Yeah.
Thank you for your faith, and,
I got it, man.
but you have to get into politics before that sort, yes? I think that's right.
But, I would say that from the catchment area, that Graham County is probably the lowest contributor to this. Now, historically, I don't know how that came about. Smoky Mountain Center was at one time 7 counties, and how that developed. As this model has grown, and the legislature has saw fit to change the model that we operate under, And as we all know in our respective counties, and we are seeing the change in sales, the potential change for sales tax and what those implications are. Once the almighty General Assembly hands down a mandate and says, hey, this is your level of payment, guess where that's going to be until you know different. So I think that, you know, once all of this shakes out and we have a better understanding of where in fact the state of North Carolina is going to go with mental health, I mean, what we heard today about the substance abuse facilities should send chills. Knowing that there's not enough in the state of North Carolina now, and the dollars that are being handed down are going to have to manage going forward and save money. So we're willing to talk about it. But, you know, right now we're providing a lot of mental health services with jail transport staff.
Yeah.
That's our mental health facility right now. Okay, what else do we have besides a frightening PowerPoint presentation? I'm always scared of PowerPoint.
Well, Tracy and Shelley have taken pity on me.
Oh,
I think
great.
we're gonna-
And they're adding.
This board's full.
Shelley, we're out here at 8 o'clock.
I know, that's fine.
8 o'clock.
You'd have to start.
If you set a rate, we wanted to do this is to keep everybody here.
All right, Shelley's talking, y'all be quiet down there.
I thought she was passing out stuff.
Yes, we really want to keep you in the loop with everything that we're doing as an organization so that you have information in a very timely manner. And in February, the board of directors had a planning retreat, and a part of their retreat is they took time to look at our past vision, mission, value statements, and they went through the process of redefining that. As you know, we've changed a lot in the last several years and really needed to revisit the vision, mission, and value statements. They also, as part of a policy we're required to have, put it into a policy that also outlines our organizational structure. So this is a policy that helps you clearly see our vision, mission, and value statement, and there'll be a quiz on it at the next meeting. I won't you memorize it. And if you have questions, this also gives you the opportunity to have answers about how we're organized as an organization. So Brian, I don't know if you want to say anything more about it.
Give Tracy a chance.
The last time this document had been revised was in April of 2012, which was 2 months before Smoky went live as a Medicaid managed care organization. So for anybody like Billy, who was on the board back then and kind of has a memory of that document, this is a significantly different document. Smoky has a totally different organizational structure than we had when we were just an LME. The mission, vision, and value statement, I think it's fair to say that Brian and other senior leaders really spent a lot of time trying to craft something that really reflects who we are as an organization, while also giving us that vision for the future. But what I think, and Chuck, you were at the meeting where it was approved, I think for your purposes, what you might find most helpful is it really has a clear explanation of what we currently do and what departments are responsible for which functions, because I can tell you that we still have a lot of confusion in the community about what we do and what we're responsible for. We still get a lot of calls from county representatives and sometimes from judges who are still a little unclear on what our role is. So I hope that you'll take this back. Feel free to make copies, share it with anybody, your DSS director, anybody else who has questions and needs to know more about what it is that we do and just more detailed information about our operations.
Is this up on the website too?
It is not. We can certainly put it on the website.
We're in the process of the vision, mission, values being placed on our website.
So if you have any questions, I'm happy to answer them. And
It wasn't so easy to do, let me tell you.
One of the best things we've done this last 2 years.
It's nothing like trying to write it down. Okay.
And have everyone agree.
Let me take a quick vote. Okay. Let me talk a little bit about what we've been involved with here in the last, probably close to 6 months. Everybody who's very close to state politics, I think, would agree that way up at the tippy top of the list, in terms of legislative action and interest, is Medicaid reform. You know, without even trying about it, we've talked about that a bunch of times tonight, really. If for no other reason than the financial aspect of it, you know, the state does not want to be at risk for Medicaid payments. It does not. That's what it accomplished when it got the waiver for us going and got all the LME MCOs up and authorized to manage care. They need to do the same thing on the healthcare side. They need to do the same thing, many would argue, for all the entitlements, all the services available in the Medicaid program. Dentistry, long-term care, et cetera, et cetera. Getting there is the hard part, okay? They did it with us, now they need to do it with the rest of the system. You know, in the short session, there was a lot of back and forth around what the goals of Medicaid reform should be, what the timeline should be, what the structure should be. And basically what you saw forming was a plan that the state had, and it was released through the Secretary of Health and Human Services. You had a plan from the House of Representatives, and you had a plan from the Senate. So you had more or less 3 plans. And trying to reduce those down into something that you could say, well, at the end of the day, if you look at all 3 of these, what is the plan going to be? Is the effort that we undertook at Smoky, and we did that in concert with 2 other organizations, Mission Health and Mayhem. And that led us into, you know, very extensive kind of planning initiative and an approach that we have been proposing to the General Assembly that is something that we believe can work for Western North Carolina and also be a scalable approach that could be appropriate for the rest of the state. So, it's kind of the introduction to this whole last section. And whether we talk about it in terms of, you know, there's a PowerPoint that I'll go through. There is this 3-page summary, and it's probably 1 page longer than normally we try to do for something like this, but, you know, I don't think there's something more complicated for a state to do than to try to reform its $12 billion Medicaid program. So there's nothing easy about this. You know, so we've made our best efforts at trying to reduce some very complex thoughts and issues of public policy down to 3 pages. And you have that. And this has been what you know, myself and representatives of Mission Health and one of our board members, Dr. Heck, who is the CEO at Mayheck, have gone around to different hospitals, had a discussion about this, specifically and then more broadly about Medicaid reform. A week ago last, I spent 4 days in Raleigh and met with more legislators than I can remember, actually, and you know, had a pretty good reception there. Again, talking about what we're doing. And what I have for you here is a slideshow that kind of reinforces a lot of those main ideas. If you want to get yourself something to drink and some popcorn, I'll get this loaded up and we can get started. You did bring the popcorn, did you, Shelley?
Oh, darn.
All right, next time.
I have beads. Does somebody want beads? They brought beads for us.
Popcorn beads. Oh.
Nope. It'll be a miracle if we can make all of this work properly.
While while you're getting that ready, I am embarrassed at how ignorant I am about how mental health services are provided in Haywood County West. But a friend of a friend, a School of Government faculty member, has retired to Swain County. He has a daughter with mental health issues. How does she access mental health care in Swain County?
Well, it would depend who the providers are there. Most likely to be our comprehensive provider would be Appalachian.
So where would she go to find that out?
Call our call center, 800 number,
Okay.
24/7, 365, that gets answered. And that's
All
the
right.
easiest, that's just right off the bat, that's the,
Call the call center
Right.
and ask, okay. So would you all have known if you had a relative, friend with mental health issues, where to send those people? Judy, you would know. What about Charles, you would know. Greg's not even, all right, forget it, I'll stop there.
You know.
Well, but you raise a good point.
Yeah.
Because I was cruising the website and I pulled off the Transylvania contacts today. And, some of these phone numbers, one's a Raleigh area code, another number is a Hendersonville number. So trying to put the pieces together, it's kind of challenging. Most of them seem to be associated with Alliance, which I've taken an employee to before. Some I'm looking at the addresses thinking, where is this? And realize a couple of them are inside schools, but that wouldn't be an adult mental health provider. So it's tough. It's absolutely very challenging. Mhm.
Okay, Brian, you ready? Gonna make me go get my popcorn? Oh, you got 35 minutes? You keep saying that. Oh, we'll be out of here long.
Well, one thing that's going on is the prison population is starting to rise again. And we don't need to be putting mental health people in prison. That's just a too expensive a way to do it, and it's not helping their lives. So, that's a direct cost that's coming to us some other way, and the legislature's going to have to deal with that somehow. Right. Yeah, I just. Budget item for a growing need is, it's assuming that's what we're wasting. And we can find it and get around it.
in the PDF, I don't think I can do.
It's nationwide, it's been going down for a long time, it's just turned around.
This was the PowerPoint I did at the staff meeting a month or so ago, which again, as far as trying to cover the waterfront, would be pretty good for our purposes. And really the first part of it is, pretty consistent with what I talked about. You have to figure that an organization like us, at least as far as I'm concerned, has a really big stake in all of this. Okay, when you think about what we do, the services that we provide, the people and the care that we're responsible for, what happens to the Medicaid program, that is a real big deal for us. And we don't want to see what we do undervalued, nor do we want to see the services that are available for the population in need undermined in any way, shape, or manner. And if I don't choose exactly the right words, forgive me, you understand what I'm saying here, okay? So, the notion that we would step forward, or I guess in our case, that I would, and go to other organizations and say, hey, there's a big thing coming along here. What are we going to do about it? MAHAC, Mission, what are you folks thinking about all of this? Are we on the same page? Is there a thing we can do together? Do we think differently? Can we develop a relationship? Because I think you can see how each of them has a big stake in this too. Not the same one that we do, but a complementary one. And these questions are the same questions that other organizations are asking themselves. So it didn't take long for us to get to a point where we realized, oh yeah, we're asking ourselves the same questions, and a lot of the same answers are coming back to us. So, I guess you could say, well, why is it, do we really have to change? Yeah, we do. If for no other reason than the state doesn't have a good ability to manage the Medicaid program when you come right down to it, they're just not in the best position to do this. And why is that? Think about it. What are the things they can do? They can eliminate services, they can change eligibility, and they can reduce rates. And I will tell you, none of those things are easy for providers or individuals who receive care to tolerate. Those are kind of gross ways to manage something. Rather than manage care, what we do, where we start off at the beginning of the year, let's say, knowing we've got a fixed amount of money, and we got to operate within that in a way that's going to work for people. That's a lot different than the state just saying, okay, we're going to save $50 million, we're going to eliminate this service or this program, or we're going to reduce reimbursement by 3% across the board, right? That makes sense to you? So it is really a logical conclusion that something like this would have to happen. The other piece about it is, there's so much interest in whole person care. Now, do we do that now? Yeah, we do. We do it despite the fact that there's a lot of limitations to it. And, the other side to that is there's, and I can talk about this both in terms of the good things that we're doing, kind of the bright spots of light out there, and we have some fantastic programs we're very proud of. We also know, like the statistic there towards the bottom, if you have major mental illness, you're not going to live as long as somebody who doesn't. And it isn't even going to be close. We're talking about decades less time. Okay? I mean, just think about that for a minute. You happen to have this particular disease, okay? You're going to live 10, 20, 30 years less than somebody else. I mean, in the healthcare system, when we have that, people go nuts over it, right? I mean, there's advocacy, there's money, people are upset, how can this be? We've got to help people. Do you hear that same kind of advocacy for our folks? No, you don't. It's called stigma, okay? And we got a long way to go with all of that, okay? Long way to go. A big piece of that is access to care. Access to health care, and it's kind of a bell curve with it. There's the access to care to begin with that people don't have, and then there's the people that receive care, but it is not well managed. Say, for example, we have situations with individuals who get prescriptions at 15 different pharmacies, 20 different prescriptions. I mean, it doesn't make any sense. Well, why? Nobody's managing it. It's kind of like back to the same story about the kids being in the psychiatric facilities. Nobody's managing it. It just happens. Okay? So without some oversight of that, clinically it doesn't do any better for people. And the cost, I mean, it'd be one thing if the cost, if somebody was, getting some benefit out of what's getting spent. You can hardly even say that sometimes. So all of this is in need of big correction. So this is, I'll tell you a funny story. Everybody looks like, well, we might have some younger folks in here. You remember in elementary school, I know you do, Chuck, overhead projectors, transparencies? Teacher would have those, and you'd see, like the Louisiana Territory and the this and the that, they layer over, and like the body and the organs, and it's really a great tool. They're called Venn diagrams, actually, where you show, you got this, you got this, you got that. Well, what's that little triangular piece in the center there? Okay, that's what we had to figure out. It's just what I was saying before. The governor had his plan, and the secretary talked a lot about that. The House had a plan, and the Senate had a plan. So the most logical thing that I thought we could do would be to say, okay, well, of all of those plans, what are the consistent things? What things, if you peel away all the rest of it, if you could find 3 or 4 things that everybody would agree to, what would they be? Well, here's what they are. Back to the money thing again. The state's not going to be at risk for Medicaid. There's going to be risk sharing or some kind of capitated budget. Okay? Now this is for the healthcare side of things. Got to be whole person care. Nobody's going to stand up and say that's not a good idea, right? We all know it is. Some good examples of it, we need more. And finally, how are you going to, what's the service delivery mechanism going to be for all of this? Well, accountable care organizations, or provider-led organizations, provider-led networks. They would like to see on the healthcare side providers to do it to themselves, accept limited amounts of money, have certain requirements around performance, and kind of manage all of this themselves. So if you could craft a plan that had all of that in it, wouldn't that be what everybody is looking for? Well, that's what we did. That's what we did. And then we said, and if you want this, here's what's going to have to change. The first big thing is we're going to need another waiver. We're going to need an 1115 waiver, because that's going to provide us with the flexibility to be able to deliver care on the healthcare side in a way which is going to allow these things to happen. Look at that, I got them all right. It's amazing. Seriously, those are the basic, that's at the core of whatever Medicaid reform plan occurs. It's going to be that, what I said, or it's going to be commercial managed care. And right off the top, if you do that, you're taking about $2 billion out of the state for overhead and profit to a zip code that's not in North Carolina. So you got to figure, is that going to be worth it? And do you think they could really do a better job? I would say no. I would say I don't know anybody who can do, a better job at this right now than us. We have the greatest stake in this. We're here. You come to meetings, you have me. If you have a commercial managed care company, that's going to be a very, very different relationship. Okay, and again, we're back to talking about the money. So, a little bit about information about accountable care organizations. These are somewhat less prevalent in the Medicaid program. Mission Health Partners has a Medicare ACO that they've already received a license for. They have about 200 some primary care physicians signed up to be part of that network. Better care, better health, lower per capita costs. Again, all the kinds of things that folks are after. And we need to, along with that care, create benefit plans that facilitate whole person care. Okay? So that there are fewer barriers to delivering the kind of care that physicians would like to deliver. And that our providers on the behavioral health side would like to be able to have reimbursement to do and pay more attention to people with chronic health conditions. You know, they know that their clients, in many cases, live 10, 20, 30 years less also. But because the systems are not really set up in ways that are conducive to going in and seeing the psychiatrist and talking about your medication, any issues with that, and then also talking about how you're doing with your diabetes and your diet, and more about smoking cessation. Any issues with cardiovascular disease. See, that there's not time for that because they have to get on to the next client. There's so much demand. And they don't get reimbursed for doing that. See? And just that story over and over and over again. A little bit more about accountable care organizations. A lot of good literature out there. You know, this notion that you can take that type of service delivery and you can have behavioral health be part of it is just a basic tenet. You know, that's been part of our discussions with Mission and MAHEC, and they completely get that. You know, MAHEC is responsible for the business management of Mission Health's primary care sites, and they also have several themselves. All total, I think it's something like 35 different primary care sites. So again, that's like ground zero for all of this. That's where the greatest potential for integrated care exists, in that primary care site and in our comprehensive care centers. So, what has to happen? To have all of these things, okay, these three things I talked about, you could look on a continuum of financial risk, but what the state wants is for financial risk to be on with someone else. So, you know, let's just say we're way over here is the ideal scenario. Capitation, no risk for the state, okay, which is fine. So we just put a little dot there. Flexibility. Now, what I'm going to tell you is somebody running a capitated health plan, okay, I'll do that. But if I'm going to have the responsibility for that, I'm going to have some flexibility. I can't do it in the same way that it used to be done in the fee-for-service program. Any willing provider, contract with anybody. We're going to have rules about performance. We're going to have rules about quality. We're going to pay for certain things. We're not going to pay for other things. And we're going to have relationships with those providers that can do that. And we're not going to have relationships with those that can't, because it's about the people that need the care in a limited amount of money. So on flexibility, yeah, we're going to need to be out here, if you want me to be out here. And then authority, well, what rules are we going to have to break, or what rules are we going to have flexibility with in the Medicaid program? Well, you could take, there's a thing called a SPA, which is a state plan amendment, where the state can petition the federal government for some changes in the existing waiver. They can kind of nibble at the edges and make some small changes. Except that currently, the Department of Health and Human Services doesn't even have the authority to be able to do that unless the General Assembly grants them that authority. Okay? You could tinker around with the 1915 DC waiver, which is what we have now. Or what we're saying is, look, if you want that, and we're saying if you want that, then we got to have this. The authority that's needed is a Section 1115 waiver, which is a research and demonstration waiver. And that would give us the flexibility on the healthcare side to basically do all the things that people want to do. Simple story, right? So, gives you some idea there. This is not an uncommon approach that states have had. The phase we're in terms of the legislative process is educating folks in the General Assembly around our approach, and that a requirement would be legislation that would impose upon DHHS to submit an 1115 waiver. and that we would have great interest not only in helping to craft that legislation, but then in also the waiver application process. Just a whole bunch of kind of general things about population health. The notion that it's not just about treating someone when they're sick. It's about doing things to make health better for everyone. And it's really kind of an odd thing to get your head wrapped around. You have to sort of get ahead of it. And again, we don't have reimbursement and benefit plans designed in a way that is really ideal for that now. We're always chasing around behind it. So, we had a good reception with our plan. In terms of not only the Western delegation, but recognized leadership on Medicaid reform. And we would hope that in this session we'd see something that would be suited to the approach that we're looking at. So, 15 minutes to go. If you have any questions, I'd be happy to try to answer them.
Brian?
Yes, sir.
So really, Smokey and the LME MCOs have a role in, they're really the only group advocating for the clients. I guess the legislatures think they are, but when you set a fixed budget and as demand increases, you don't raise it, that's really a denial of reality, but that's okay. So I'm wondering who's advocating for the patients? Not just the ones that we cover and get reimbursed for, but the ones that Smokey denies coverage to. Who is advocating, who's their voice at the legislature? And I am glad to hear that you're presenting some good alternatives and lobbying. I mean, basically educating, as you said, not lobbying, educating how, the need, because they obviously don't see the need that you feel as an organization. I mean, you're turning away people every day that may not fit into this category, but might need services as well. So I'm curious as to who's there besides the Child and Family Advocacy Committee that is looking out for our clients and our well-being.
There's a lot of advocacy that goes on. I mean, there's the advocacy agencies, there's a lot of, the providers, are certainly very interested.
So are they working in a united front? I mean, I know you see the other MCOs you're working with, but I mean, basically they're going to get finite amounts as well, the capitation, and I mean, that's fine if you provide enough money to provide the services, but
I think there is a group that I'm part of that's at a very high level in the state that is a group of providers, and it's a group of LME MCO folks that are really, working very hard to be on the same page. Certainly in terms of kind of public policy and major legislation. That if we could do that, that would be a really powerful relationship that could do some good, and we have already. We're just like, you got to remember, when you get to Raleigh, we're just like anybody else. We're selling shoes, okay? Or roads, or, fill in the blank. I mean, think of it in terms of your county budgets.
well, and the stigma, like you said, you can't forget the stigma, that this notion that just get over it, or this is not an issue, but mental health. I mean, it's pretty clear that that's a huge cost coming down our. If it's not here now, it's going to hit all of us sooner or later.
Well, what Billy's talking about, how can we get county commissioners to realize that this maintenance of effort money, in our 5 groups, Allegheny gives the most per capita. We can't even get our commissioners to raise that amount, or even try to get together and set an amount. It doesn't have to come from Raleigh, does it? The maintenance of effort. I mean, the county commissioners in Smokey's area could get together and say, okay, this is the percentage that we're gonna give. And you new people, just went off the board in December, and I've been a county commissioner for 10 years. So, Billy knows
Put in
that.
some
We've had
time,
this
yes.
discussion several times before in the past. Vicki?
Yes, I've heard Billy several times. You seem to have been a little quieter on that. Can't believe I thought you would be good on the big board. Have you finished with the slide presentation?
Yeah.
Brian, what else do we have to discuss tonight in the 12.5 minutes we have left until 8 o'clock? Nada?
I would like to echo what you all are saying, and again, I don't want to talk too much, but
Oh, well,
in the role, as I'm trying to figure out the role of this advisory council.
I think we are too.
In so many ways, the first couple of meetings we've just sat here, and the first one we talked about money and lack of, and then this one has been another education on a ACO model that's going to be handed down whether we want it or not, or whether it's going to work or not, or however that may be. And in other advisory councils that I sit on, the ones that are successful, I mean, I think it's as you said, I mean, I think that you pick topics that are pressing in regards to mental health. And because ultimately we're here because we don't have a seat on the board of directors. And we want our local community and the voice to be heard. So we want to bring topics to the board of directors that we feel they should address. So, I think
And
our
then for them
time
to
would be
take it
better
on.
spent doing that and discussing and formulating those things that we can provide some consensus on in a lot of ways.
So that's what you would like to do next time?
And thus, I mean,
Right?
I think this is important to have
This-
some time
this really
to
is, yeah.
update and to hear, but I think that, you all as commissioners and fellow managers to be able to bring the local issues and let's get something that we can take to the larger, the appointed board of directors for Smokey to act on.
And if we could agree on it, then we've got the numbers of, at least, all of us saying this is an important issue for us too.
Absolutely.
That's a
You know,
great
it
idea.
may be maintenance of effort, to figure out a way to resolve this matter. It may be, we need to tell the state, heck, you need to be worrying about building substance abuse centers rather than telling them to figure out how to divide $1 in them.
Yeah.
I think those are important asks that are very relevant.
So would we all like to come up with issues which we would like to see this advisory committee address next time? You, Greg, obviously have some in mind. Anybody else?
It won't take long to do help. I think that we all can have a top 3 locally and,
Right.
email them in
Yeah, we
to
said
Ryan
it, shall we?
Yeah, and I'd say, we've had orientation and just one other meeting for this. One of the things we want to do is, a lot of people are coming from a whole, lots of different levels of knowing or understanding the system. So we have wanted to give you a good sort of underpinning of where we are. Last time, the financial information, that's something the counties have been asking for. I think what I would think would be great is, if we do this, is that we also provide information to help inform you about whatever topic it is so that there's a basis and that we have a mix of maybe, there's information we want to share with you, that the board wants to share with you, like some of we did tonight, and then you may have other things. But I think it's important for us to continue our learning so that when we're talking about issues too, we're talking from here's the data or the information we have, and we can certainly do that based on the topic. Brian? Brian, sorry.
Vicki, we still fighting with commissioners and across the state the battle of perception on mental illness.
Oh, yeah.
Because, everybody can see, you got heart problems, you can come to Mission, I have, get it taken care of. But, it's not always apparent that somebody's been taken care of that's mentally ill and their lives have been changed. So I think educating our fellow commissioners and the public on the need is just as great as the physical need of a person.
Some of those stories that we've heard in board meetings, and you have one staffer who has been through quite a bit himself with drugs and alcohol, spent time in jail, and now he's a counselor. I would love for everybody in this room.
He has a great story.
He has a wonderful story of how he overcame that.
Yeah.
Well, so, maybe, and we've done, this is what we've done with our board meetings. We always make sure we have a part of it that is really, Jerry's happy to know that we still care about people, right, Jerry?
Right.
It's still all about people. That's never lost on me. That's why we do that aspect in our board meeting. Now, we can't ignore the business side of what we're doing. This is not, some frivolous little organization we got here. There's a lot of, substance behind all of what we talked about. And there's politics, and there's money, and it's big stuff, but it still is about people. And one of the things, we've touched on tonight is, you could say is, maybe this is the biggest problem we got is all about stigma.
I think it is.
That might be the one common thing. If you want to pick something to do something about, there you go. Education, community education, stigma. Because then that gives you a platform then for people to maybe care about this a little bit more, have more understanding and compassion, and maybe generosity.
Because you got people that think, if a person works hard enough, they can overcome those problems. That I hear that all the time. Yeah, they get over it themselves if they're strong enough.
Get over it, that's what
Yeah,
you hear.
get over it. Yeah.
That's Vicki, we could have, next time around arrange for something more oriented towards, more education around, what recovery is all about, for example.
What I think I heard was that these folks want to bring up issues that are concerned to the county, and then perhaps here, I can't remember that guy's name.
Richie Tanner.
Richie Tanner, and then I've already forgotten what you said. I was so busy looking at the clock. So.
But aren't we really and truly, we're talking about how do we quantify a return on our investment?
Yeah.
Because you're going to sell it to your fellow board members, or you're going to sell it to your citizens, then you can show return on the investment. I mean, Transylvania County just lost their birthing center because 40% of the infants born in our hospital were born to drug-addicted mothers.
Oh my God.
We have a substance abuse problem in our community, and based on the sheet of information about where to go for mental health, I'm involved in the community. I wouldn't know where to go based on the sheet I have. So how do I justify giving you how many millions of dollars or hundreds of thousands, whatever it is I give you? I don't know that. Sorry, I'm new to the board relatively. So how do I justify that? How do I stand up at a meeting and defend the contribution I'm sending to Smoky Mountain when I don't have a mental health bed? I had a 20-year-old spend 23 days in the emergency room waiting for space. So how do I sell this to my citizens? I can't until we can show that we're making substantive changes in the lives of our citizens. We're not going to be able to justify it. So that's what I mean, yes, I'm new to this group, but that's what I need to hear from you. That's what I need to understand.
Well said.
Well, I think based on that too is an understanding of why things are happening. I know in the past, people look to Smokey as like, well, it's your fault, you just fix it, where maybe, may or may not be within our control. Or even if we have impact on it, what are the limitations? State funding, how little state funding we get to serve so many people, and so I think part of what you're saying is there are issues that we need to address, but what we can help do is support, what's the basic information behind this topic, and have people who will talk to you about their experience in a particular area, whether that's a provider who does a certain kind of service or people who've experienced things, because it's very complex. I mean, a lot of those issues are very difficult for a community to deal with. And part of why we want you to be with us in our working and moving forward is so you have that understanding, so you can share it back with the community. So, I mean, I think it's a reciprocity sort of that we would have together.
And you know, and two, don't ever forget from Smokey's standpoint, you know, you've got the electeds in the room. You know, if there's something that needs to happen with the representation at the General Assembly,
Yeah.
you know, these folks, not me, I was hired, but, you know, these folks that are elected by the people, were, you know, they speak for the folks. So if there's something happening there that you don't like, you know,
Yeah.
let them know. So
Yeah, if we can advocate
you've got
as a
the
group.
biggest advocacy group in
One of the best things that can come out of this group is that you really become aware, understanding, and the link back to your community. I mean, when we had a board of directors, the county commissioner, that was their job, is to go back, you know, to be that voice of what we
And they
do
were.
to their board.
In our area.
And
They were
so-
very good liaisons.
Yeah, this could be something we could really work to accomplish.
We've had in our county in the last 4 years, 35 deaths from drug overdose. 35. And
With a
we are
population
counting
of less than 8,000.
8,000, that's exactly right. And we have, usually the CFO is on the money being spent at the priority level. And that would be a priority level in our county, rather than drawing pictures and doing art and employing 6 or 8 people to do that. And we do it year after year after year after year. And it's not okay in the area where we live.
Well, it is hard to quantify, you know, programs that work, but the selling point is if you don't deal with mental health, the costs are more later. And that's really the big, the bear in the room, is people don't realize that emergency rooms, sheriff's department, everybody's gonna bear the cost of this, not to mention individuals and their families that whose lives, and it just drives me crazy to have to keep putting a dollar value on somebody's life when everybody's life is precious. And so that to me, but that's the way it is. So you got to quantify, you got to say, okay, this program's working somewhat, and if we don't have it, I mean, what are the alternatives? So it's a tough sell, like you say, and keep it up.
Well, we've had a good meeting tonight. I think we got educated about this wonderful model that's going to be happening in Asheville and some other county. I can't remember, Caldwell County? In eastern North Carolina. And we want to get some information to Shelley about what issues we want to talk about. We're going to get better educated ourselves, have a real life story. Perhaps.
We'll work together. What I'll do is I'll send out an email, a request based on what we talked about, and then we can work together for the next agenda.
Okay, I've made a motion and seconded that we go home.
And please, don't forget to bring us your mileage form, and if you,